back, my lovers of learning. This is Night Nurse, and today we're going to talk about part 2 of fluid and electrolytes and get into the big 3 electrolytes. Those are being sodium, potassium, and calcium. Understanding what they do helps you understand what happens and what goes wrong when they're either high or low. Remember, we're drawing electrolytes in the vascular compartment, so we're talking about the levels in the pipes. So sodium, which is hypo or hypernatremia, we'll talk about, it maintains the extracellular fluid volume. Remember, it's what maintains the hydrostatic pressure or blood pressure. If you have any questions, refer back to part 1, and it helps with nerve conduction. Potassium, hypokalemia or hyperkalemia, it is huge in nerve conduction, specifically in contraction of cardiac tissue, and it's highly influenced by insulin. If you don't have insulin, then potassium goes up, or in the case of acidosis, any type of acidosis, potassium goes up. Calcium, hypocalcemia, hypercalcemia, it's big in calming skeletal muscle and strengthening cardiac muscle, so it's kind of bipolar. It calms skeletal muscle and it strengthens cardiac muscle contraction. An associated player is phosphate. And really, you just have to remember that phosphate antagonizes calcium, which means whichever way the calcium level, or whichever way the phosphate level goes, calcium will move the opposite direction. So if you have high phosphate, you'll have hypo or low calcium. So just remember, phosphate, high or low, moves calcium the opposite way. So let's talk about sodium. Normal level is 135 to 145 milliequivalents per liter, and it's the major cation in the extracellular fluid. 90% of the solutes in the vascular pipes is sodium. So it's the big guy on the block that's causing this osmotic sucking pressure we're talking about. It's very low inside the cells. Functions, volume control, maintains hydrostatic pressure, keeps the fluid in the pipes, and that keeps blood pressure. Remember, Ladies Night at Club Oasis, we control sodium so that we can control where water is. Nerve conduction, sodium helps with nerve conduction and muscle contraction, so both high and low sodium, you'll see the patient has neurological abnormalities. Big player in fluid shifts between the vascular and interstitial compartments. It's regulated by renin-angiotensin-aldosterone system and antidiuretic hormone, which we talked about in part 1. And sources are diet, IV fluids, lost through perspiration, urine, feces, having high ADH, which dilutes the sodium, and having low renin, which causes low sodium. So hyponatremia, or sodium less than 135, what are the causes? We can have sweating, vomiting, diarrhea. We can also have excess water. Antidiuretic hormone secreted too much. That's called a syndrome of inappropriate antidiuretic hormone. That's going to over-dilute the sodium and cause hyponatremic. We can do this by giving somebody hypotonic fluids. And hormonal imbalances. If a patient doesn't have aldosterone, that's called Addison's disease. Then they will not have any aldosterone, telling the kidneys to reabsorb sodium and thus water, so we'll see hyponatremia. Manifestations, low vascular osmotic sucking pressure, so hypovolemia, hypotension, and edema, because any fluid that is around doesn't want to hang out in a vascular compartment that doesn't have any sodium. Ladies Night at Club Oasis, low sodium, water will go somewhere else. Fluid imbalances shift towards the cells, vascular hypotension, while at the same time the fluid is all setting in the interstitial fluid, causing edema. You get impaired nerve function, muscle weakness. If you get fluid around the brain, cerebral edema, this causes confusion, coma, seizure, and even death. The treatment is to give hypertonic IV fluids. They need some sodium. Now, hypernatremia, sodium greater than 145, is just the opposite. Causes are insufficient water, so ADH can mess this up the other way. Instead of having inappropriate antidiuretic hormone, you have none. And this is called diabetes insipidus, so the kidneys excrete too much water, and that leaves the sodium very, very high. This can also happen if you lose the thirst mechanism. You can also have high sodium with excess water loss through polyuria, insensible loss, or through HINCS, which we'll talk about with type 2 diabetes, where the sugar actually goes into the urine and pulls water with it. So they end up losing sugar and water, but they don't lose sodium. So it causes hypernatremia. Manifestations causes, you see, an increased osmotic sucking pressure within the vascular pipes. So fluid like crazy is going to come to the vascular pipes, right? Tons of sodium. Where's water going to go? Towards the pipes. So fluid is pulled, sucked back from the cells into the vascular compartment. It could increase blood pressure, but the cells will crenate and you'll lose cellular function. This can cause impaired neurological function, can cause muscle weakness. You won't have very much urine output because you're trying to hold on to all that water, and they'll be very thirsty. Now, potassium, its normal level is 3.5 to 5 milliequivalents per liter, and it's the major intracellular cation. Serum levels are very low. Most potassium is inside the cells. That's why it's only 3.5 to 5 when you draw it in the vascular compartment. Functions, important in nerve conduction. It's important in the action potential. It's critical in the cardiac cycle. High or low abnormal potassium levels will adversely affect cardiac conduction. It's regulated by the kidneys, renal, both potassium excretion and aldosterone. So the kidneys are very important. It's controlled by the sodium-potassium pump, which is insulin dependent, so insulin plays a role too. Also, acid-base balance. Acidosis will cause potassium to shift out of the cell. So in this instance, we have a cell. Potassium is trying to go in the cell. That's where it wants to be. And then what happens is you have very high hydrogen ion, which is acid, inside the cell, and it gives the potassium the boot, and you find it out in the bloodstream. So acidosis equals hyperkalemia. Conversely, in alkalosis, there isn't very much hydrogen ion inside the cell, so the cell welcomes potassium inside, and so more potassium comes into the cell than normal, and so that can lead to alkalosis, giving us hypokalemia. So acidosis, hyperkalemia, alkalosis, hypokalemia. Very important, because when we talk about different conditions, then you'll see that an abnormality in potassium will follow this rule. Insulin controls potassium because insulin and glucose are required for the sodium-potassium pump to work. If you have no insulin function, you have no potassium being transported inside the cells, so a loss of insulin means hyperkalemia, more of it's outside of the cell. Potassium sources, kidney reabsorption, cellular injury and death. If lots of cells die, then all those cells release their potassium. So a massive burn or trauma can cause hyperkalemia, and then potassium loss through vomiting, diarrhea, kidney excretion through diuretics, or sodium reabsorption. Remember, whenever you bring sodium in, you're kicking potassium out. Sodium-potassium pump is a revolving door. So what do we see with potassium abnormalities? Hypokalemia less than 3.5. What causes it? Excess aldosterone is going to cause more sodium to come in. Potassium will be kicked out. It's a revolving door. Excess glucocorticoids, because glucocorticoids act like aldosterone. So that's as complicated as it gets. Potassium wasting diuretics will make you dump it, will dump potassium out, and decrease dietary intake, especially if you're also taking a potassium wasting diuretic. Alkalosis welcomes the potassium inside the cell, which means your vascular pipe level drops. So that can cause problems. And insulin administration shifts the potassium back into the cells, again causing hypokalemia. What do we see with hypokalemia? Well, we see cardiac dysrhythmias, and they can often be lethal. Ventricular fibrillation, ventricular tachycardia. If you look at the EKG, the T wave of an EKG will follow the potassium level. So the T wave in hypokalemia will be low or flattened. Skeletal muscle weakness. This could cause decreased respirations, fatigue, pins and needles, constipation because the muscles aren't working very well. And the treatment is to slowly give potassium. You have to give it very slowly, though, because of the problems that can occur with giving someone too much potassium and causing hyperkalemia. Now, hyperkalemia is greater than 5 milliequivalents per liter. So what are the causes? Renal failure. Kidneys are key in getting rid of potassium. So when the kidneys fail, acute or chronically, you're going to have hyperkalemia. Aldosterone deficit means you're not holding on to sodium and kicking out potassium. Rather, no aldosterone, the kidneys excrete sodium, which kicks potassium back into the bloodstream. So Addison's disease will cause hyperkalemia. Acidosis kicks the potassium out into the bloodstream, hyperkalemia. Potassium-sparing diuretics, burns or trauma because all those cells release all their potassium. DKA is something we'll talk about with type 1 diabetics. Acidosis shifts the potassium into the blood. Plus, there's no insulin in DKA, so you have more potassium being left out into the bloodstream. Hyperkalemia. The manifestations of hyperkalemia, they may look similar to you. Again, cardiac dysrhythmias, cardiac arrest, cardiac standstill. The EKG changes, though. If the T wave follows the potassium level in hyperkalemia, you would see a peaked T wave, and that's what you see. Muscle weakness, fatigue, nausea, paresthesia, pins and needles, these are all things that sound very similar to hypokalemia because they are kind of similar. So the treatment is to give lower potassium, is to lower the potassium. So you'll give insulin or something like that. Now, calcium, it is huge in extracellular cation to store inside of bone, and its functions are skeletal muscle stability. Calcium calms skeletal muscle, and at the same time, it will have the opposite effect in cardiac tissue, and calcium strengthens cardiac tissue. So what we see also are it strengthens bone. It is what makes bones get strong, and hemostasis and blood clotting requires calcium. So in short, calcium is calming the contractions of skeletal muscle while it's strengthening contractions of cardiac tissue. So this bipolar effect of calcium is what you see when you see abnormalities. It's regulated by parathyroid hormone and calcitonin. Parathyroid hormone releases and raises blood calcium levels. So parathyroid hormone means calcium. Calcitonin is the opposite. Vitamin D plays a role, and phosphate, remember, the level that phosphate goes, it will shift calcium in the inverse or opposite direction. So what do we see? With hypocalcemia, we have causes being hypoparathyroidism. If parathyroid hormone causes the release of calcium from the bone, then if you don't have parathyroid hormone, then you'll have low blood calcium. So hypoparathyroidism equals hypocalcemia. You can also have malabsorption, diet deficiencies, serum albumin deficiencies because calcium is carried on albumin, or high phosphate, hyperphosphatemia, will push you towards hypocalcemia. Alkalosis, excess calcitonin, which is the opposite hormone of parathyroid hormone. What do we see? Well, if calcium calms muscle and we are hypocalcemic, it means the muscles are not going to be calm. So you'll get increased skeletal nerve excitation, you get muscle twitching hyperreflexes, carpopedal spasms, couple of tests, Chavostex and Trousseau's will be positive, laryngospasms in the throat, abdominal cramping, and they can even have tetany where they have sustained muscle contraction. Now, cardiac tissue requires calcium. So if you have hypocalcemia, that means cardiac contractions are not going to be strong. So you have decreased cardiac strength, conduction delays, arrhythmias, and low blood pressure. So you give calcium salts for that. Hypercalcemia, the causes are parathyroid related. Hyperparathyroidism will cause excess bone demineralization and dump calcium into the bloodstream, causing hypercalcemia. Hyperparathyroidism equals hypercalcemia. So any other release of calcium from the bones, like from a cancer, immobility will lead to bone demineralization. Increased intake of calcium will increase calcium. And then there's this milk alkali syndrome thing that happens, you'll learn in pharmacology with some of your medications, that causes a mess up where calcium goes high. The manifestations, the the skeletal muscle in hypercalcemia, since calcium calms skeletal muscle, hypercalcemia means the muscles will be too calm. So decreased skeletal muscle contraction, muscle weakness, hyporeflexia, lethargy, stupor, personality changes. And since calcium strengthens cardiac and you have hypercalcemia, then the cardiac will be too strong. So you have increased cardiac contractions. This can cause arrhythmias, but they'll have a bounding pulse and hypertension. Now, if the excess hypercalcemia is caused from hyperparathyroidism, you're stripping bone. So if you're stripping bone of all of its calcium, you're weakening the bone and you're dumping calcium into the bloodstream. So you can get bone destruction and pathological fractures where they don't need any trauma. Their bones just break because they're weak. And you can also get kidney stones. So the treatment for this is to give phosphate salts, because that's going to lower, if you give phosphate, it will lower the calcium level. So that's electrolytes. Next, we'll get into acid-base balance and doing ABGs. Thank you for watching. I hope that was helpful for you. If you found it helpful, then be sure to subscribe at the Night Nurse Learning channel. You can do that by clicking down here, and as I add videos, you'll see them first. You can also go to nightnurse.com, where I'm always building new content to try to help you all learn. So thank you for listening, and I'll see you next time.